Hello everyone and welcome back to the Orthodontics webinar series. My name is Omar and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today for the third session of this series. Before we begin, I would like to briefly introduce the International Association of Dental Students, IADS. IADS is a global organization that connects dental students from all around the world and promote academic exchange, professional development, and international collaboration. This webinar is organized under the SCORE Office of IADS, the Standing Committee on Research and Education, which focuses on advancing research, education, and global engagement. Through SCORE initiatives, students have the opportunity to learn from experts, participate in international activities, and broaden their academic experience. We are delegated to continue this orthodontic series, a specialty that contributes significantly to improving oral function, facial harmony, and long-term oral health. We hope today's session will be insightful and beneficial for everyone, and it's a great pleasure to welcome Prof. Mehdi today, and we sincerely thank him for joining us and for sharing his expertise. To introduce our speaker and guide us through the session, I would now like to hand over to my colleague Emiliana.
The mic is off. Thank you very much.
Okay, sorry. Hi, everyone. We are delighted to have you with us today for this lecture entitled Early Orthodontics Intervention, Spotting Red Flags and Clinical Signs to Miss Nothing. Today, we will explore the importance of identifying early clinical and functional warning signs that may influence craniofacial growth and develop. It's my great pleasure to introduce our speaker, Dr. Mehdi Sersab. I know I mispronounced. He is a French board certified consultant orthodontist. He completed his residency at the prestigious PTA Salpêtrière Hospital in Paris, where he developed particular expertise in complex craniofacial condition, including cleft palate treatment and obstructive sleep apnea. Alongside his clinical practice, Dr. Sersab is actively involved in educational and as a clinical supervisor and lecturer with a strong focus on functional orthodontics and digital workflows. His international training includes advanced education at the Tweed Foundation in Arizona, USA, and he is widely recognized for integrating innovative technologies into orthodontics care. As a researcher and published author, he continuously contributes to the advancement and evidence-based orthodontics. Currently, he is preparing a national conference in collaboration with American Orthodontics, focusing on the integration of advanced biomechanics and digital indirect bonding. He is based in Paris right now and serves as a medical director of a high-tech digital clinic where he specialized in 3D plant treatments and the management of skeletal discrepancies. So without further ado, I will now leave the floor to our doctor for this amazing lecture. Okay, let me know if you managed.
Perfect.
Okay.
Oh, so much. Is it okay? Is it okay or no?
Okay, I can see your notes. So try to share again.
And now?
I cannot see the slides.
We did it just 2 minutes before. So, and sorry.
I can see the notes.
I'm really sorry because and now? It's really sorry.
Don't worry.
I'm not panicking at all because we just did it like 2 minutes ago.
Don't worry.
So, Partager, sorry. Tac, partager.
Okay, now I can see your screen. Okay, perfect.
Thanks a lot. Thanks a lot. Very, very thanks a lot. Your French pronunciation was perfect. Thank you. And so, first of all, I would like to thank the IADS and SCORE team for the invitation. It's really a great honor for me. A special thank to you, Omar Saleh, for contacting me, and Emiliana, the entire organization and moderation team. It's a great honor me to give this webinar right after Professor Daniele Manfredini. I saw his presentation this morning, very, very informative. I'm also very happy to speak today in front of students for whom I have the deepest professional respect. So, I had the chance to complete my full-time postgraduate orthodontic residency in Paris at Pitié-Salpêtrière Hospital, one of the biggest in Europe, where we studied many aspects of orthodontics: craniofacial anomalies, rare disease, biomechanics, segmented mechanics, tweed, Burson, everything in orthodontics. It was really, really nice. I also trained at the Rothschild Hospital. It's the reference center for rare disease and craniofacial disease, including cleft lip and palate and genetic syndromes. And I had the opportunity to work in sleep apnea departments at Saint-Antoine and Bichat Hospital in Paris. And I also had a university diploma in sleep apnea. Throughout my training, and still today, I have always tried to keep learning through national and international conferences and programs such as the PITS Master and the Tweed Foundation, for example. My approach to orthodontic has been shaped by clinical practice, hospital training, biomechanics, grow, earthway, and interdisciplinary care. I try to be complete orthodontist, but I think I will never succeed. The work is very, very big. So let me start with a number that should catch our attention: 77%. What is this? According to a survey in partnership with the French Federation of Orthodontics, 77% of parents consult an orthodontist mainly for aesthetic reasons. They come because they see something crowded teeth, protrusive incisors, narrow smile, or smile that does not look harmonious. And of course, aesthetics matter. A smile is social, emotional, and deeply connected to confidence. But for us, the real question is, when parents come for what they see, are we able to detect what they do not see? And now the second number, 43%. Less than one parent out of two knows that orthodontics is not only about aesthetics, but orthodontics is a medical discipline. It's about oral health, function, growth, stability. It's not only straight teeth. So there is a clear gap between what families consult and what orthodontists can actually diagnose and treat. And this is where our role begins. We need to help parents to understand that behind a smile, they may be breathing, chewing, growth, function, and long-term health. And let me finish with this shocking number. Only 9% of parents know that orthodontics is connected to breathing. Yet breathing is one of the foundations of facial growth, occlusion, and function. So when we examine a child, we should not only ask, how are the teeth? We should also ask, how does this child breathe? Through the nose or through the mouth? Because ventilation is not a detail. It's one of the bases of orthodontic stability. Here I want to introduce you the population we are focusing on today, the growing child. At 3 years old, most children already have their complete primary dentition. That means 20 primary teeth with the primary molars established and functional. For me, this is the first key age for early orthodontic observation. Not because we want to treat every child at 3 years old, but because this is the age where we start guiding families, stopping prolonged pacifier use, thumb sucking, and other parafunctions. It's also the age where children should begin learning essential habits: how to blow their nose, how to breathe properly, and how to understand toothbrushing as part of daily health. At 6 years old, things become more interesting. We reach the second key age. This is actually when children enter school and begin developing stronger social habits. It's also the beginning of mixed dentition, the child starts losing primary incisors, which are replaced by permanent incisors. At the same time, the first permanent molar erupt. These teeth are extremely important because they play a major role in establishing the dental occlusion. At this age, the child also becomes more autonomous. So harmful habits and orofacial dysfunction, such as thumb sucking, pacifier use, mouth breathing, or abnormal tongue posture should ideally have disappeared. At 6 years old, we are no longer only observing. We are identifying the first real orthodontic red flags. And at 8 or 9 years old, we reach the third major key age for orthopedic and orthodontic interception. This is a very important period, especially in girls, because we are approaching the prepubertal stage with an acceleration of the general and maxillofacial growth. This is often when orthopedic treatments give us the best results. This is also the age where we must carefully check dental eruption, especially the maxillary canines. Do they have enough space, and are they erupting in the right direction? At this age, the child should also be autonomous with toothbrushing, nasal blowing, and daily hygiene habits. Parafunction should have been stopped, orofacial dysfunction should be controlled, and the child should begin to understand the importance of sleep, breathing, and healthy routines. So, this pictures of me working in my office is what most people imagine an orthodontist. A clinician working with pliers, metal wires, brackets, appliances, straightening the teeth, moving the teeth with all the technology and everything. Someone who aligns teeth, adjusts arches, and creates a beautiful smile. And yes, this technical part is real. It's part of our daily work. But for me, orthodontics goes far beyond the wires and pliers. We need to explore a much wider picture. How the child behaves at school, how they sleep, how they breathe, how they function every day. This is the kind of medical and holistic orthodontics that we should promote and practice. Because before correcting the teeth, we need to understand the patient. So the position of the teeth is not isolated. This is the result of genetics, growth, breathing, function, and daily habits. The first principle is airway first. Before looking at the teeth on the occlusion, we ask one question to the parents. How does the child breathe? We can often see it immediately, even before the child sits in the chair. Is the mouth open? Are the lips relaxed? Does the child breathe through the nose or through the mouth? We are not replacing the ENT specialist, but breathing must be our first clinical filter. Because when nasal breathing is impaired, the tongue, lips, mandible, sleep, and growth all start to adapt. So airway is often the beginning of the functional chain, and sometimes the origin of malocclusion. The second principle is face first. This does not mean that aesthetics comes before medicine. It means that the face shows us how the child is growing. A narrow smile, lip incompetence, a mandibular retrusion, facial asymmetry, or long face pattern are not just cosmetic details. They are clinical signs. So we do not look at the face just to judge beauty. We look at the face to understand growth, function, and balance. Third principle is to intercept early. This does not mean treating every child early. It means seeing children early enough to know who should not wait. This is very, very important. In a growing child, timing is biology. A narrow palate, mandibular shift, or abnormal eruption path are not details. They are red flags. Early interception means acting at the right moment, before treatment becomes longer, harder, and more complex. Let me finish with very important principles that I think it's the most important. For me, we cannot treat growth alone. A child is not only occlusion. A child breathes, sleeps, swallows, speaks, chews, and grows. As orthodontists, we guide the jaws and the occlusion, but for the airway obstruction, allergies, tongue posture, and oral habits, we need the right partners. They are partners. Because stable growth is rarely the result of one appliance. It's the result of coordinated team around the child. So the consultation starts before the child sits in the chair. It starts with a questionnaire: sleep, breathing, allergic, habit, fatigue, and school behavior. And it continues the moment we welcome the child and the parents in the room. We observe quietly everything in the child: the lips, how the child is moving, how he sits. Does he seem to breathe through the nose or through the mouth? These first impressions are already clinical signs. Before examining the teeth, we first observe the child. Really try to have this principle in your practice. Observe the child, look at him, sit at his position before looking at the mouth. So, now I would like to give you the general roadmap for the clinical screening. We will organize the red flags into 5 main categories. First, the sleep screening. You will see, I think it's the most important in our screenings, because sleep quality often reveals breathing problems. Second, the postural and morphological red flags, where we observe the child's posture, facial pattern, and general morphology. Third, the facial red flags, because the face often tells us how growth is developing. Fourth, we will talk about oral red flags, where we look at the teeth, the arches, the palate, and the occlusion. And finally, functional red flags: breathing, swallowing, tongue posture, lips, and oral habits. The idea is simple. Before treating, we must screen systematically. So, we begin with sleep, because many functional problems become clearer at night. During the day, a child can compensate, but at night, these compensations disappear, and it's the perfect period to look at the child. Snoring, restless sleep, mouth breathing, or poor sleep quality can reveal an underlying airway problem. For us, sleep screening is important because sleep is directly linked to breathing, craniofacial growth, and facial development. It appears during the night. To screen sleep, we need simple structure. I think it's the best for this. It's called the Beers algorithm and helps us to ask the right questions. First, the bedtime. How does the child fall asleep? Daytime sleepiness: is the child really rested? Awakenings: is the night continuous or fragmented? Regularity: is the sleep rhythm stable? And finally, snoring. Is there a warning sign for airway obstruction? This is not diagnostic, it's screening to find and to identify children whose sleep and breathing need closer attention. So start with the sleep screening. Let's watch this short video. I invite you to observe not only the child, but the quality of the sleep. Is the sleep calm? Is it restorative? Does the breathing seem easy? For now, just observe. On the next slide, we will analyze together what this video is showing us. When we observe a child sleeping, there are 5 signs to remember. First, snoring. And let me be clear, a child should not snore. Loud breathing at night is not cute or normal. It should raise suspicion. The second point is struggle sounds. Small noises that suggest effort during breathing. Third point, apneas or breathing pauses, even short ones. Fourth, mouth breathing, which often means that nasal breathing is not efficient. And finally, sleep bruxism. In children, grinding is not always just a dental habit. Sometimes it may be a muscular response to help open the airway. So the real question is not, does the child make noises? It's, is the child sleeping peacefully or struggling to breathe? When a child struggles to breathe during sleep, the whole body may start to react. This is why we should not only listen to the breathing, we should also observe the body. That's what I tell parents. I tell them, go to see your children when they sleep and tell me what are they doing. A child who moves constantly at night may not simply be an active sleeper. Sometimes the child adopts an unusual position, head extended, sitting almost upright, or sleeping in a posture that seems strange to the parents. There are what we call survival postures. Then we have night sweats. A child who sweats heavily during sleep may be showing signs of increased effort and physiological stress. Bedwetting is also important, especially when it appears again after the child was already dry at night. And finally, parasomnias, nightmares, night terrors, sleepwalking should also make us ask whether the sleep is truly stable and restorative. This is what I call survival posture. The child is not sleeping in a relaxed position. The body is adapting, sometimes in a very unusual position, simply to find air and make breathing easier. So when parents tell us that the child sleeps in a strange position, we should not ignore it. Sometimes posture during sleep is already a sign of airway struggle. Parasomnias include night terrors, frequent awakenings, and fragmented sleep. These children may cry, move a lot, wake up repeatedly, and seem agitated during the night. For us, the key point is simple. A child who does not sleep peacefully may also be a child who is struggling to breathe properly. This is as simple as this. In this video, I want you to observe the morning consequences of poor sleep. The child has spent the whole night in bed, but the sleep was not necessarily restorative. Look at the open mouth, the tired appearance, the difficulty waking up. This is the kind of situation parents may describe as, he sleeps a lot, but he is still exhausted in the morning. I don't understand, doctor. And for us, this is an important warning sign. The problem may not be the quantity of sleep, but the quality of breathing during sleep. So in the morning, fragmented sleep can show three simple signs. First, sleep inertia. The child is difficult to wake up. He doesn't want to go to school. Second, dry mouth and thirst, often suggesting mouth breathing during the night. Third, morning headaches. When the child is suffering from morning headaches, it may be because he's sleeping mouth open and he is dehydrated. So the question is not only did the child sleep all night, it's did the child wake up restored. Now, during the day, after the child went to school, poor sleep may look different in children. Adults become sleepy when they don't sleep well. Children often become overactive, and this is important to know. They may seem restless, impulsive, inattentive, or emotionally unstable. And sometimes these children are quickly suspected of ADHD. Of course, ADHD exists. But before concluding, we must ask, how does the child sleep? Because sometimes the child is not simply hyperactive. He's exhausted and compensating during the day. In this video, we see the daytime consequences of poor sleep. The child struggles to concentrate, becomes irritable, and may not even fall asleep during the day. This is very important clinically. So before labeling the child as inattentive or hyperactive, we must ask how this child sleep. Now, we can attack the second point, the postural and morphological red flags. Because breathing difficulties do not only appear at night. Over time, they can leave visible signs during the day. The way the child stands, the head position, the shoulders, the lips, the tongue posture, and the general facial expression. Our goal is not to judge the child's appearance. Our goal is to read clinical signs. Because in early orthodontics, posture and morphology are not just aesthetic details. They are information, very precious information about how the child breathes, adapts, functions, and then finally grows. When nasal breathing is difficult, the body often finds another way. And one of the most visible adaptations is posture. A mouth-breathing child may project the head forward, forward like this, extend the neck, open the mouth, and gradually organize the whole upper body around this need to breathe. This should not be dismissed as simple bad posture. Very often, it's compensation. When the airway feels restricted, the child may instinctively change the position of the head, the mandible, and the neck to make breathing easier. The more balanced posture is not a more balanced posture is not only more elegant, it reflects more stable relationship between the head, the airway, then the mandible. The same logic applies during the sleep. Some children extend the head, rotate the body, and adopt unusual sleeping position because the body is still searching for air. As we saw it earlier. After observing sleep, we now move to the child's face and posture, because chronic breathing difficulties do not only appear at night. Over time, they may leave visible clues during the day. The mouth, the lips, the tongue posture, the head position, the shoulders, the facial expression, all these elements can tell us how the child is adapting. This chapter is about learning to read these signs. Not to label a child from their appearance or to judge him, but to recognize when facial growth and posture may reflect an underlying functional imbalance. In early orthodontics, the face is not just aesthetics. The face is clinical information. So look at this child and look at this one. Is it the same? I don't think so. The face is clinical information. When we examine a child, we should not look immediately at the teeth. We should first take a step back and observe the face. Not aesthetically, but clinically. The eyes, the nose, the lips, the chin, the profile, the symmetry, they can give us clues about breathing, muscle tone, and posture. One sign alone is not a diagnosis, but several signs together may reveal the pattern. So the goal is not to judge the face, as I told it many times. The goal is to read the child. Here we are looking at the first facial impression. Before measuring anything, we simply observe the child at rest. Does the face look tonic, alert, or relaxed? Or do we see tired expression, reduced facial tone, lips apart, and an open mouth posture? These signs do not give us a diagnosis by themselves, but they tell us that the child may be functioning in a different way, breathing through the mouth, keeping the tongue low, compensating with reduced orofacial tone. And this is exactly the point of interceptive orthodontics, to notice small signs before they become large problems. Now we can talk about the eyes. The eyes can tell us a lot. Dark circles, puffy eyes, or allergic shiners are not only signs of fatigue. They may suggest chronic nasal congestion or inefficient nasal breathing. When they appear with open mouth posture, snoring, or disturbed sleep, they become important clinical clues. Here we start by observing the nose. Narrow nostrils, pinched alar base, chronic nasal obstruction, poor nasal airflow, or recurrent ENT history, breathing problem, should immediately alert us. A very simple clinical test is the Gödel test. We gently pinch the nostrils and observe how quickly they return to their original shape. If the nostril remains collapsed or reopens very slowly, this suggests poor nasal valve function and possible nasal obstruction. So the nose is not just an anatomical detail. It is one of the first clinical indicators of the child's breathing quality. This slide follows the previous one. I'm often surprised to see children, sometimes even 12, 13, 14 or older, who still do not know how to blow their nose properly. And this is important because children grow in increasingly polluted environments with more allergens, rhinitis, sinusitis, and recurrent ENT problems. So from a very young age, we should teach them simple nasal hygiene, how to blow their nose, how to rinse it with saline or seawater, and how to keep the nasal airway clean and permeable. As orthodontists, we are often in a frontline position to detect breathing and ventilation disorders. Our role is not to replace the ENT specialist. We are not ENT specialists. We are not allergists, but to identify the signs early and refer the child to the right colleague when needed. So as I told you, chronic nasal obstruction and recurrent ENT stories are not simple things to observe. It's very important. Now we will talk about lip competence. You will see I love this one. This is very important red flag. Lip competence, meaning the ability to keep the lips gently closed at rest, is early. Here the first question is simple. Are the lips naturally closed? If the lips are apart at rest, the child is no longer breathing exclusively through the nose. This may be related to mouth breathing, low tongue posture, and reduced lip tone, meaning weaker resting activity of the lips, or an unfavorable vertical growth pattern. A short upper lip, meaning that the upper lip does not inadequately cover the upper incisors, or an inverted lower lip, meaning a lower lip turned outwards, are not just isolated details. They are part of the same functional picture. At rest, the lips should close naturally. If they do not, we must ask why. On this slide, we look at effort. Some children can close their lips, but only by forcing. And this detail is very important. The K sign is mentalis contraction. The chin becomes tense, sometimes dimpled. This means the lip seal is not spontaneous, it's compensated. Clinically, this may reveal mouth breathing, lip competence, protrusive incisors, or altered facial growth. So the question is not only, can the child close the lips? It is, can the child close the lips without effort? Sorry. You can look at this picture. It's one of my patients, and you can see on the left pictures, she's closing with effort. She's closing the mouth with effort, and we see the chin tension. Just to let you know that we can change this later by surgery, but we're not always happy to do surgery to patients. Here in this case, we only changed the position of the chin. So we made the chin go more forward. Why? It's not only aesthetical, it's functional. The surgery made this part may go forward, so to let the lips close without effort. And this patient told us she sleeps better just because we changed the position of the lips and the chin. So this is something to keep in mind. We must close the mouth without effort. How we continue with the lip competence at rest? In this child, the sign is very clear. When he is relaxed, the mouth remains open. And when the mouth is open, air naturally tends to pass through the mouth rather than the nose, simply because there is less mechanical resistance in the mouth. This is where the dysmorpho-functional spiral begins. Mouth breathing modifies lip posture, tongue posture, mandibular position, maxillary growth, and facial development. So an open mouth posture at rest is never just a detail. It is a major clinical sign that must alert us early. Here we see how functional problem can progressively become morphological problem. An open mouth posture, mouth breathing, and altered tongue posture can influence facial growth over time. This may lead to what we call long face pattern, increased lower facial height, steeper mandibular plane, clockwise rotation of the mandible, and retruded chin. and then the problem becomes self-perpetuating. The dysfunction creates the dysmorphosis, the morphological change, and the dysmorphosis then makes the dysfunction worse. It is a vicious circle. The child adapts, the face changes, and the new morphology reinforces the functional imbalance. Finally, the vertical dimension, one of the easiest red flags to observe is the gummy smile. When a child gives a natural, relaxed smile and shows too much gingiva, we should pay attention. Very often it reflects an excessive vertical growth pattern. And in many cases, although not always, it may be associated with narrow maxilla. So a gummy smile is not only an aesthetic detail, it's a clinical sign that we must include in our diagnosis and treatment planning. Let's now talk about facial asymmetries in growing children. In most cases, except in genetic condition or rare diseases, these asymmetries are often functional at the beginning. They may be linked to mandibular shifts, crossbites, altered posture, or asymmetric function. And this is why early diagnosis is so important. If we identify the cause early, a functional asymmetry can often be corrected before it becomes a true skeletal asymmetry. So the goal is not only to observe that the face is asymmetric, the goal is to understand why and to intervene before growth makes it permanent. When we look at the facial asymmetry, there is a few simple signs to observe. First, chin deviation. The chin is centered or shifted to one side. Second, asymmetric smile. Does the smile move evenly or more to one side? Like in this child, it's moving to the left side. Third, the occlusal cant. Is the dental plane horizontal or tilted? Fourth, a unilateral crossbite, which is often associated with a mandibular shift. And finally, a facial midline discrepancy. Is the facial midline aligned or there is visible deviation? These are simple signs, but they can tell us a lot about how the child is growing. Here's a simple clinical tip to differentiate a true skeletal asymmetry from a functional shift, as we saw it before in this little girl. We place the patient in a centric relation. We relax the mandible and we gently put it in a centric relation. The idea is to guide the mandible gently, help the patient relax, and see where the mandible naturally sits. If the maxillary and mandibular midlines become centered again, this is not a true skeletal laterognathia. It is a functional lateral deviation, a kinetic asymmetry. And this distinction is very important because the treatment is completely different. We don't treat a functional shift as a skeletal shift. We do not treat these at the same way, and it's easier to treat as a functional shift than a skeletal asymmetry. We have the radiograph of this little girl. This is a panoramic X-rays of the patient, so we can see significant crowding with a particular risk of maxillary canine impaction. We see it, the maxillary canines. Combined with an extraoral and intraoral clinical examination, this leads us to correct the transverse maxillary dimension. This can be done with the removable or fixed appliance. But in my practice, I prefer the fixed expanders. In this case, simple correction of the transverse dimension helps to recenter the mandible and allows more harmonious growth. Here is the result after only 1 month of maxillary expansion. The mandible is now centered. The midline diastema has closed spontaneously thanks to the tension of the transseptal fibers between the incisors. At this stage, the active correction is done. Now the K is regular follow-up to monitor the eruption of the permanent teeth and make sure growth continues the right direction. To summarize all this section, many postural and morphological red flags can be regrouped under a classic clinical pattern. You should all know this. It's the adenoid facies. This term must be used carefully. It is not caricature, and it is not a judgment on the child's appearance. Sorry. It is a clinical pattern that reminds us that long-term breathing difficulties can influence the facial posture and growth. On the next slide, we will break down its main component. Here, we break down the main components of what we call adenoid facies. First, the open mouth posture. The mouth remains open at rest, which often suggests chronic mouth breathing. Second, long face tendency. The face grows more vertically with increased lower facial height. Third, lip incompetence. The lips do not close naturally without effort. Fourth, tired eyes. Dark circle or tired facial expression may reflect poor sleep quality. Fifth, we have the narrow maxilla. The mandible, the upper jaw may be constricted, often with a high and narrow palate. After, we have a low mandibular posture. The mandible tends to drop downward and backward. And finally, we have the altered head posture. The child may adapt the head and neck position to make breathing easier. Taken together, these signs are not diagnoses by themselves, but they are strong clinical clues that should lead us to investigate breathing, sleep, and function. We now move to the oral health red flags. After observing sleep, posture, and face, we enter the mouth. You see the time we took to enter the mouth? Here we will look at the teeth, the arches, the palate, and the occlusion, because the mouth often shows the visible consequences of growth, function, and breathing. The key point is very simple. We must take the time to examine the mouth properly. Sit at the child's level, use good light, and make the examination calm and comfortable. Do not only look at the teeth. Look between the cheeks and the teeth, behind the tongue, under the tongue, and carefully observe soft tissues. The lips, the cheeks, tongue, frenula, and mucosa give us important information. They help us to understand function and often explain the origin of dysmorphosis and malocclusion. A good orthodontic diagnosis starts with a complete oral observation. We now move to the arch morphology and the transverse dimension. This is one of the most important parts of early orthodontic screening. When we look at the upper arch, we are not only looking at teeth alignment. We are looking at the shape of the maxilla. It's wide, narrow, U-shaped, V-shaped, symmetric, constricted. A narrow maxilla is often one of the first visible consequences of altered function, especially mouth breathing and low tongue posture. So in this section, we will focus on one simple question. Is the upper jaw developing wide enough to allow normal breathing, occlusion, and facial growth? Here we can clearly see a narrow palate with a V-shaped dental arch. This tells us that the maxilla is narrow in the transverse dimension. And in many cases, this is not only a dental problem, it's a functional problem. The shape of the maxilla is influenced by the balance between the tongue, which normally helps to widen the arch from the inside, and the cheeks muscles, which pushed inward. When this balance between two muscles is disturbed, the maxilla adapts to the surrounding muscular forces and functional matrix. So a narrow arch is often a clinical sign of a broader functional imbalance. Now you can see the constriction, especially around the premolar, the constriction of this palate. In the red, we can see the forces from the cheeks, the muscle, from the cheeks, and from the palate, we can see the tongue that should push on the palate and make it wider. This diagram illustrates the function imbalance we discussed on the previous slide. Normally, the tongue should rest against the palate and act as a natural guide for maxillary growth. But here, the tongue is positioned too low, so it no longer plays its role as a confirmer of the upper arch. As a result, the surrounding muscle forces, especially the cheeks and facial muscles, can dominate. They push inward, restrict transverse maxillary growth, and contribute to a narrow upper jaw and a deeper palate vault. So the message is simple. When the tongue is low, the maxilla loses one of its most important growth stimuli. Here, we have the opposite situation. This is the case where the tongue is properly positioned against the palate. By resting high, the tongue applies a gentle and continuous force on the maxilla, and it balances the inward pressure of the cheeks and facial muscles. This helps guide normal maxillary growth with a wider palate vault and a more harmonious transverse dimension. So when the tongue is in the right place, it becomes a natural support for maxillary development. To continue with the transverse dimension, this is for me one of the most important clinical signs to identify and correct early. There is no negotiation about this sign. You have to correct it the earlier you can. We can see a unilateral posterior crossbite associated with a reduced maxillary transverse dimension. This is not only a shifting problem. This is a real constriction of the maxilla. And this is not something I like to leave it for later. Because when the upper jaw is too narrow, it can affect occlusion, mandibular position, facial growth, and function. So the message is clear. A transverse discrepancy in a growing child is a priority. It should not be postponed. For unilateral and even more for bilateral posterior crossbite, the standard treatment is a fixed rapid maxillary expander. The main objective is orthopedic, to open the mid-palatal suture and increase the transverse dimension of the maxilla. A small clinical tip for me: when possible, I like to anchor the expander on the second primary molars, because any mechanical force on a teeth may induce a slight root resorption. So I prefer this occur on the primary teeth rather than a permanent teeth, like the first molar. Ideally, the treatment should be performed before the age of 9, and we will see later why timing is so important. But you can make it at 8, 7, 6, 4, 5 years, the earlier you can. Here is an example of a bonded anatomical expander I did maybe 2 weeks ago. It is not cemented with traditional bands around the teeth. It is simply bonded directly to the occlusal surfaces. These appliances are produced using modern laser metal printing technology. This allows to create expanders that they are very precise, smooth, and comfortable. Clinically, it also simplifies the procedures. No separators, no band fittings, and a much faster placement. This is the type of expander we have been using in our practice for the 2 last years, with very good patient comfort and excellent clinical efficiency. Concretely, with rapid maxillary expansion, we separate the 2 AMI maxilla by acting on the mid-palatal suture. In a growing child, this suture is usually still responsive, especially before the pubertal growth peak, which is why the timing is so important. The goal is not only to tip the teeth outward, but to obtain a true orthopedic effect on the maxilla. Recent studies also remind us that the mid-palatal suture does not necessarily close completely at puberty. In some patients, it may remain responsive much later, which explains why non-surgical maxillary expansion can sometimes still be considered in adults. Here I am showing a very simple case of transverse discrepancy with a narrow maxillary arch. We decided to use a classic turn-arm rapid maxillary expander, and we performed approximately 8 millimeters of expansions. On the middle suture picture, you can see the appearance of an interstitial diastema. This is very important to explain to the parents. This space is not a complication. It is actually a good clinical sign that the expansion is working. And in most cases, the diastema closes spontaneously within few weeks, as the anterior teeth naturally redistribute themselves. Let me tell you a little point, very important. All transverse problems cannot be corrected in the same way. In most growing children with a functional maxillary constriction, we can use rapid maxillary expansion to act the transverse dimension. But there are very rare exceptions. Here, for example, one of the patients who presents a cleft lip, alveolus, and palate with a specific deficiency of maxillary growth. In this situation, the treatment strategy is different. We are not simply trying to open the mid-palatal suture. We placed a quadhelix to prepare the arch and support the future surgical correction of the transverse discrepancy. After discussing the transverse dimension, which is usually the most urgent to correct, you really have to note this. Transverse dimension is the most urgent to correct. We now move to the sagittal and vertical dimensions. Of course, these dimensions are all connected. In orthodontics, we do not only look at whether the maxilla is narrow, we also need to analyze how the jaws relate to each other in front to back and vertically. So in this section, we will focus on sagittal and vertical occlusion discrepancies and how to identify the red flags. In the sagittal dimension, meaning the anterior-posterior relationship, one of the most urgent red flags to correct is the anterior crossbite. It can have important consequences. It may restrict maxillary growth, push the lower incisors forward, and create periodontal problems over time. Sometimes it is mainly dental. However, if we leave untreated during growth, a dental problem can progressively become a skeletal problem. So this is a sign we should identify early and not postpone. Here is an example of a 35 years old patient who came for consultation in my office, and he had never seen an orthodontist during childhood. When we look at the anterior crossbite, we can say that it has probably been present since the age of 6 or 7, and the patient confirmed this. Unfortunately, when this type of problem is left untreated, it can create significant dental wear over time and dental problems. It also leads to dysfunctional and highly traumatic occlusion. This is exactly why an anterior crossbite in a growing child should never be considered a minor finding. In the vertical dimension this time, we have the opposite problem. Anterior open bites. They are often functional, especially when the tongue is positioned between the upper and the lower teeth. Thumb sucking or finger sucking can also prevent the anterior teeth from coming into contact. This can disturb chewing, speech, and normal dental development. Now we move to the anterior-posterior dimension. One of the major red flags to identify early is the excessive projection of the upper incisors. As we mentioned earlier, this can be related to functional habits such as thumb sucking or tongue interposition. But it can also be the clinical sign of skeletal discrepancy, often with a mandible that is positioned too far back. Intercepting this early is important, not only to improve a jaw relationship, occlusion, and chewing function. There are also two major reasons why this should not be ignored, and I will explain them now. In children, we must also remember the social dimension of orthodontics. Children can sometimes be very hard on each other, and visible dental differences, such as very protrusive incisors, may become a reason for teasing and mockery. This can have real consequences on the child's social life, confidence, and emotional well-being. So correcting this problem is not only about occlusion or facial growth. It can also play an important role in helping the child feel more comfortable, more confident, and better integrated socially. The second major reason to intercept excessive projection of the upper incisors is the risk of dental trauma. When the incisors are too far forward, they are no longer properly protected by the lips. So during a fall, the lips can no longer play their natural airbag role. The teeth become the first point to impact. And unfortunately, in daily practice, we see many children who, by the age of 9 or 8 or even before, have already experienced one, sometimes even two traumatic dental injuries. So reducing the incisor protrusion is not only aesthetic or functional, it's also prevention. Now we move to another vertical red flag. It's deep incisor overbite. This is not a minor finding. A deep bite can lock the mandible backward and limit its functional freedom, which may affect maxillofacial development. In some patients, this posterior mandible position can also contribute to airway problems and increase the risk of sleep disordering. It can also create a traumatic occlusion. The upper and lower incisors may injure the opposing gingiva, causing periodontal trauma, gingival inflammation, or even recession over time. Sorry. It's very hot in Paris. We now move to the dental development and space management. At this stage, our goal is to check how the permanent teeth are erupting, whether there is enough space, and whether some teeth are at risk of impaction. In early orthodontic, space is not just about crowding. It's about timing, eruption paths, arch development, and prevention. Here we are looking at primate spaces. These are physiological spaces in the primary dentition, usually behind the upper primary incisors and behind the lower primary canines. And this is something we should explain clearly to parents. Spaces between baby teeth are a good sign. They are not a problem. They show that there is room available for the future permanent teeth, which are larger than the primary teeth. So when we see primate spaces, it often reflects harmonious arch development and the good maxillofacial growth. On the contrary, a primary dentition with no spaces should alert us to possible future crowding problems, like here. The primary teeth are very tight with no space between them. And this is a real warning sign. This is a red flag. Sometimes parents say, oh, my child's teeth are very cute, very straight, and very well aligned. But in primary dentition, perfectly tight teeth are not necessarily good news. Permanent teeth are larger than baby teeth. So if there is no space at this stage, the child is in a higher risk of future crowding, with permanent teeth that may erupt misaligned or blocked. Now we can talk about premature loss of primary incisors. It is often traumatic, but it is never insignificant. We should never let parents say, oh, this is just baby teeth. No, that's false. They guide anterior function, they support the tongue position, they contribute to speech development and give important proprioceptive feedback. They also matter for aesthetics and self-confidence. So we should be careful when we say, it's only baby teeth. No, if primary incisors are lost too early, pediatric prosthetic replacement may be considered to preserve function, speech, aesthetic, and the child's comfort. This slide shows very clearly why space management matters. On the left, the premolar had no space to erupt, so it came out of the palatal side. Most likely, this happened after premature loss of primary teeth. The permanent molar drifted forward and closed the eruption space. On the right, we see the preventive solution, a simple space maintainer. Because the primary tooth was lost too early, we placed an appliance to hold the space and allow the premolar to erupt properly. So the lesson is simple. Losing space is easy. Recovering space is difficult. And the small space maintainer at the right time can prevent a long, complex, very expensive treatment later. For numerical anomalies, seeing children early can allow us to detect these anomalies, especially agenesis. Here, for an example, we see agenesis of the maxillary lateral incisors, and on the right side, agenesis of the mandibular premolar. Orthodontics cannot create teeth ex nihilo, but early diagnosis gives us something extremely valuable. It's called time, and I know I don't have too much time. So in some cases, we may decide to preserve the primary teeth. In other cases, we may extract it at the right moment, allowing natural anchorage loss and spontaneous space closure. This can avoid keeping a primary tooth for many years, only to replace it later with an implant. But if we discover this problem late at 13, 14, or 15 years old, our options are fewer and treatment often becomes longer and more complex. So the key message is simple. Early diagnosis of agenesis does not mean immediate treatment. It means intelligent planning. Now we move to eruption, anomalies, and palpation. And I love this one and always do it with my patients. In early orthodontics, eruption problems are major red flags. A tooth that does not erupt at the right time or it is in the right direction can become a complex problem if we miss it. And before asking for an X-ray, we must start with a clinical examination. We palpate the alveolar ridges, vestibulary and palatally. We try to feel whether the tooth is here, whether it's progressing, and whether its eruption path seems normal. Radiographs are extremely useful, but they are second-line examination. The rule is simple. Clinical examination first, radiograph second. Never do radiograph to a child we didn't examine it. At the age of 8 to 9 years old, palpation of the alveolar ridge is mandatory. We must palpate the buccal vestibule above the primary canines and look for the canine bulge, the small swelling that indicates the eruption path of the permanent canine. If this bulge is absent, or clearly asymmetric compared with the other side, it is a red flag. It may indicate ectopic eruption or palatal impaction of the canine. In that situation, clinical observation is not enough. Radiograph investigation is required. Now radiograph will help us. Here, the clinical palpation was negative. We could not feel the maxillary canine on the alveolar ridge, neither vestibulary or palatally. That is exactly when radiographic examination becomes necessary. And on this X-ray, we clearly see that the left maxillary canine is retained and impacted. And I would suggest you to make another radiograph. It's a 3D radiograph called CBCT to see the relation between the canine and the incisor. If around 8 or 9 years old, the canine bulge is not palpable and not radiographic investigation is performed, the canine may continue its ectopic path and become impacted. At that stage, treatment becomes much more complex. Surgical exposure, orthodontic traction, long mechanics, and careful protection of adjacent roots. This is a patient I treated recently. I put 2 mini screws and I am taking out the canine. I told the patient that the treatment could last 2 years or maybe 3 years. Do you imagine? When children are not seen early and regularly, we may discover very complex situation here. He's a patient I saw recently, a child around 7 years with a blocked incisor and severe root delaceration. The tooth is in an abnormal position, and the root development is extremely compromised. In this situation, orthodontic traction becomes very uncertain, and the tooth may be even non-restorable. We have no root on this teeth. This is exactly why annual screening matters. With regular clinical follow-up, palpation, eruption, monitoring, and radiograph when indicated, we can identify abnormal eruption paths much earlier. I'm trying to go maybe a little faster. We now move to the soft tissue, the frenula, and the aerodigestive tract, because orthodontic diagnosis is not only about teeth and bones. The lingual frenulum is something we must screen clinically. The test is very simple. Ask the child to open wide and to touch the incisive papilla with the tip of the tongue. If the child cannot touch it, or the tip of the tongue becomes heart-shaped, we should suspect a restrictive frenulum. And functionally, this matters. Because if the tongue is anchored too low, it cannot rest properly against the palate. It cannot, you remember what we said, fully play the role of shaping the palatal vault. Second thing, the hypertrophic labial frenulum is assessed by gently pulling the upper lip. If the frenulum is thick, low inserted, and creates blanching of the papilla, it means there is a real traction on the gingival tissue. Clinically, this can contribute to maintaining the midline diastema between the upper and the central incisors. But timing matters. We do not treat every frenulum immediately. In most cases, we monitor it until the eruption of permanent canines, unless there is a clear function of periodontal hygiene-related indication. We have to identify the frenulum early, but choose the right timing before treating it. The oropharynx should be inspected systemically too during the clinical examination. This is very, very, very important. We look at the size of the tonsils, the available airway space, and we can use the Mallampati classification as a simple screening reference. When tonsils are hypertrophic, inflamed, or almost kissing, they can significantly reduce the pharyngeal airway. Functionally, the child may compensate by lowering the mandible or pushing the tongue forward to breathe more easily. Do you remember the child sleeping badly? This is one of the main reasons. So, when pediatric obstructive sleep apnea is confirmed, especially with adenotonsillar hypertrophy, adenotonsillectomy is considered the first-line treatment. The goal is simple: remove the mechanical obstruction and restore a more physiological airway during sleep. Modern surgical techniques, including partial tonsillotomy, radiofrequency, or laser-assisted approaches, in selected cases. We have helped to reduce post-operative morbidity. We do this a lot in our city in France, and we have the chance to work with a lot of ENT specialists. This is a very simple procedure, and it's the gold standard in obstructive sleep apnea in children. Now, the last functional red flags, with the functional. We now enter the last chapter. Here we are no longer looking only at shape and morphology. We are looking at how the child functions. Earlier, we spoke about sleep, which is often synthesis of many functional problems. Now, we will focus on daily orofacial functions: breathing, swallowing, chewing, tongue posture, and oral habits. A dysfunction is a function that does not work optimally. A parafunction is a harmful habit, like thumb sucking, nail biting, or chewing object, that should be stopped as early as possible. So in this chapter, the key question is, how does the child breathe, swallow, chew, and use mouth every day? Before speaking about orthodontics, we need to remember one basic point. Children are designed to breathe through the nose. The nose filters the air, warms it, and humidifies it before it reaches the lungs. It also allows the use of nitric oxide produced in the nasal and sinus mucosa, which helps with antimicrobial defense and oxygen exchange. This point is really fascinating. And the nose creates a natural resistance to airflow. This resistance is not a problem. It helps to regulate breathing rhythm and support better pulmonary function. So nasal breathing is not just a habit, it's a physiological system that protects the airway, improves oxygenation, and supports healthy craniofacial growth. After the benefits of nasal breathing, let's look at the consequences of chronic mouth breathing. The first, the causes are often obstructive. Enlarged adenoids, enlarged tonsils, allergic, chronic rhinitis, septal deviation, or other nasal obstruction. Then come the dental and periodontal effects. The mouth becomes dry when you breathe with the mouth. Saliva is reduced. The risk of decays and caries increase. And gingival inflammation becomes more frequent. Sorry. There are also morphological effects. A narrow and high palate, posterior crossbites, downward and backward mandible rotation, and increase the lower facial height. So mouth breathing is not just a bad habit. It can affect the teeth, the gums, the face, and the whole function balance of the growing child. Here we can clearly compare two very different swallowing patterns. On the left, we see an infantile swallowing pattern. The tongue comes forward between the teeth and the lips contract to help the child swallow. On the right, we see a more mature, functional swallowing pattern. The lips stay closed, the tongue elevates to the palate, and the tongue drives the liquid backward toward the throat. This transition should progressively occur when the primary molars establish stable occlusal contacts. After the age of 6, persistent tongue thrusting, like on the left video, or lip contraction during swallowing should no longer be considered normal. It must be taken seriously because it can maintain open bites, alter tongue posture, and interfere with stable orthodontic correction. This is where lingual and labial re-education becomes essential. Swallowing is just not a function we observe, it's a function we must correct. I will go faster. I have maybe 3 or 4 things to say. In this patient, we can see a narrow maxillary arch with a clear constriction of the lateral receptors. You can see on the diagram the tongue is positioned downward instead of resting against the palate. So it is no longer supporting the maxilla from the inside. This leaves the latellar muscles, the cheeks and the masseters, and the surrounding soft tissue free to push inward the maxilla arch. Here we see the opposite situation. The tongue is well positioned against the palate. This matters because the tongue is a powerful muscle. When it rests high, it gently pushes the palate and balances the inward forces of the cheeks and lateral muscles. Now we can see a good growth of the maxilla, and this help a better growth of all the structure in the mouth. The tongue position is so important. The tongue is not only about tone and height. Its position can also be asymmetric. Here, for example, we see lateral tongue thrust. The tongue pushes more on the one side than the other side. As a result, the open bite is more pronounced on the right side. Here we move to another very common orofacial dysfunction, the blocked nose. It's very, very important, very important. A child with chronic nasal obstruction, rhinitis, allergies will naturally tend to breathe through the mouth. And this is why nasal hygiene is important. Parents should teach children from a very young age how to clean the nose properly, nasal rinsing, saline or seawater sprays, and learning to blow the nose effectively, because a clear nose favors nasal breathing. After nasal obstruction, we also have to think about allergies. In my practice, I often refer children to an allergist when the history suggests allergic rhinitis or recurrent nasal obstruction. The goal is to identify the allergens and understand why the upper airway is chronically congested. In my practice, I often recommend this type of device. Of course, other nasal rinsing devices can also be used, as long as they deliver saline water properly. The idea is simple. Clean both nostrils every evening. Then ask the child to blow the nose carefully with tissues. This creates a daily nasal hygiene routine. And finally, we have here, we can talk about parafunction. Nail biting, finger chewing, pen chewing, thumb sucking, or pacifier sucking are not harmless habits. They can move teeth, disturb occlusion, and interfere with normal tongue posture. This slide is almost funny at first glance. An adult sleeping like a baby and still sucking his thumb. But in reality, this is something I see quite often in my practice in Paris. And you can be surprised if you ask your patient, even at this age, if they put their finger or suck their finger. Some adults, even later in life, still need thumb sucking to fall asleep. So if we don't correct this at early age, this parafunction could last the whole life. So we can go to the conclusion. As we come to the end of this lecture, I would like you to keep the central idea in mind. Early orthodontics is not about treating every child early. It's about learning to observe early, to diagnose early, and to guide growth at the right moment. If you want to become an excellent orthodontist, and especially an excellent pediatric orthodontist, you should always come back to these 4 principles. First, airway first. Before we look at the teeth, we must ask how the child breathes. Nasal breathing, sleep quality, mouth breathing, snoring, allergies. Airway obstruction are not secondary details. They are often the standing point of the entire functional chain. Second, face first. We are not treating isolated teeth. We are treating a growing face. The lip, the chin, the smile, the vertical pattern, the asymmetries, and the facial posture all gives us clinical information about growth. Third, we have to intercept early. Early diagnosis is not over-treatment. It is the ability to recognize the child who should not wait. That's what you have to say to the parents. It is the ability to recognize the child who should not wait. Sometimes a simple intervention at the right age can prevent a much more complex treatment later. And finally, multidisciplinary work. You have to work with your colleagues. We cannot work alone. The child breathes, sleeps, swallows, speaks, chews, and grows. So we need to work with ENT specialists, with pediatric dentists, myofunctional therapists, speech therapists, pediatricians, allergists, and medical colleagues. And this is really the take-home idea. Early orthodontics is not just early tooth movement. It's early vision. It is understanding the child as a whole, their breathing, their face, their function, their growth, and their future. And if we do this well, we are not only correcting smiles, we are helping children grow better. And thank you for your attention.
Okay. Thank you, Doctor, for this really interesting lecture. And it really was, because we have a lot of questions to answer.
Thank you
And
very much.
the audience really appreciate it. And you have a lot of thank you and a lot of positive feedbacks.
Thank you very much.
So basically, we will start with the questions. The first one is, if patient has lip incompetence history or mouth breathing and class 2 deep bite, how can it be treated, especially if the patient reached the age of 25?
You're not talking about children. You're talking about adult.
This one is talking about the children that did not receive the early treatment, and it's now an adult, basically.
Yeah, so we don't treat adults like children, because in adults, as you know, we don't have any growth anymore. So in my practice in Paris, I treat a lot of adults, maybe more than 50% of adults, and we use more mechanics, because we have to adapt to the malocclusion. So deep bite in general, we use braces. We use mini screws. I have pictures. If you want, you can use mini screws. And if there is a class 2 deep bite, a very big class 2 deep bite, we use a lot of surgery. In France, we do a lot of surgery.
In Italy too, we use surgery.
Yeah, in Italy too. Very, very good surgeons in Italy. Impressive. We can talk a lot about this topic, but we do a lot of surgery. If there is no growth of the mandible, it depends on if there is other problems like sleep apnea or occlusal problems, joint problems sometimes, but we use a lot of surgery.
Okay, so let's going on with the second question. What is the correct way to use a pacifier to reduce the risk of developing an overbite in a child?
This is very interesting point because the French Association of Orthodontics just released a recommendation about the pacifiers. If you want, I can translate them in English and send it to you. It's more complex because children need pacifiers in the first months of their life, because there is studies telling that pacifiers can prevent some death of very young children, because it can keep these children sucking on something so they can stay alert and not die. It's crazy to say that, but for me, pacifiers has to stop at 3. If you can deliver a simple message at 3, no thumb sucking, no pacifier, the child has all the baby teeth. We have to stop all these non-nutritive habits. And
Okay, so let's going on. In case of surgical maxillary expansion, can we place braces on the teeth while having the pellet expander in place to accelerate the treatment?
You're talking about something I had in my life. So I had surgery with a palatal expansion and I had braces. Be careful if you put, this is very technique point, be careful, you will have to expand the maxilla, sometimes up to 1 centimeter. So when you put the wire, you have to maybe to cut it before the surgery or make a loop.
Okay.
Because you have to you have to not block the expansion. So you can in some cases put braces to accelerate. It's not a good a bad idea. Sorry, it's good.
Okay. So in case of absence of primary space, can guide serial extraction fix a future crowding problem?
Very good question, and this is something
And when is it indicated? Sorry.
Yeah, this is a very good question. You're talking about extraction before the teeth make the eruption.
Yeah.
It is something I use in some cases. It's very rare. Maybe I use it 3 times a year. It is when we are sure there is no space for the teeth and there is no skeletal problems. There is very big difference between the white of the maxilla and the mandibular and the white of the teeth. When the teeth are too big, no maxillofacial problems. We know that there will be no space. We are sure 100%. On the radiograph, we see that the teeth is blocked 100%. We can do it, and it's very good because it will make the treatment shorter and easier. But we have to explain it to parents, and they have to understand why we make it. And when we explain, parents are very happy.
Okay. So in children who present primarily with aesthetic concerns and no obvious functional complaints, what clinical signs should dentists be careful not to overlook when considering early intervention?
Sorry, could you just please repeat it?
Okay, in children who present aesthetical problems, basically, and not functional problems, what signs should the dentist consider to not to overlook when considering an early intervention, if needed, basically?
Okay, maybe I understood the question. If there is no functional problem but crowding or aesthetic problems, in general, if there is crowding and big aesthetic problems, you have to look other sides, like functional problems. Is the maxillary wide enough? So it's very rare to have dental problems without any functional problems. Functional problems are there is a lot of functional problems, but in some cases you can put braces on the 4 incisors and the 2 molars to correct the aesthetic. You can put these braces at the age of 7, 8. It's okay to treat the aesthetic problems. it's not a problem. It's if there is no other problems, you have the right to put braces in young age. But it's very rare. It's very rare because it's when there is too much dental problems, there is other problems. And sorry, I just have to answer the previous question. There is maybe the age. We can do the extraction of
when it's
yeah.
indicated, basically.
It's indicated between 9, 10 years. It's in general, it's 9, 10, 11 years before the premolar. It's because in 99% it's premolar. In general, it's 9 years. It's a good age.
Before the eruption of the secondary dentition, basically.
Yeah.
Is there rotational maxilla also when we are treating constricted maxilla?
There is a rotation maxilla if we
when we are treating the constricted maxilla, there is a rotation of the maxilla.
There is always side effects of our mechanics. Always. There is no very clean mechanics. In general, the side effect of expanding the maxilla is the tipping of the molar. When the molar are tipping, we are making the vertical dimension longer. So yes, it's a side effect. When we expand the maxilla, we expand the vertical dimension. But when we use mini screws, like the mini screws on the expander, we have less tipping of the teeth. It's a technical topic. I would like to talk about it with the person who is asking. But yes, there is secondary rotation of the palatal plan, the occlusal plan, because the tipping of the molars, and it will produce this. Yes. Good question.
So last one, how do you manage the communication with the parents in child with most urgent TSR cases?
I think the communication has to be very simple. We have to be very clear. We have to tell the truth. So I have a lot of screens at my office. I take pictures of every patient. I take radiographs when it's needed after the examination, and I explain the consequences of not doing anything. Sometimes I can show pictures of patients that came later. So I think this is a basic thing, and you always have to explain the treatment before we start. In my office, we always have an appointment. We do nothing. We only explain with pictures, radiographs, and answer all the questions. We give the parents papers with explanation because during the consultation, they cannot understand maybe everything. So I think it's just showing what's going on and showing what could happen if we do nothing. Like treatment becomes more complex, more expensive. This is a very good point, and could in some case, if we don't not treat the child, it can have problems, medical problems, breathing problems, sleeping problems. And parents, they really understand because they come for the health of their children. They love them. So just be simple.
Okay, so for the sleeping problems, you have some specific question to assess or a checklist or some. That's it.
Yeah. I thought about the BEARS, BEARS question. I can send it to you. You can find it on Google. We have questionnaires here in France. It's called Epworth. We use it for adults and children on if the children are sleepy the day, if they are going well in the school. So this list of questions, I can provide it to you with pleasure, and you can give my email, and with pleasure, I can give everything.
Okay, thank you. So we have one last question about the extraction. The girl that asked about the extraction asked again. By guided extraction, I mean that we extract the baby tooth at the time where we expect that the permanent tooth will erupt soon. So
Yeah.
she was asking about it.
Yeah, that's I understand. I understand. It's a very good question. We do it rarely again. We extract baby teeth when sometimes the root has not they are not disappearing at the same time. So sometimes the baby teeth is blocked, so it's blocking the adult teeth. Sometimes we extract the baby canine, the baby canine, to let the adult canine erupt easily.
Right.
But be careful. You be careful of not make the extraction too early because the space can close. In general, we do it like some months before the definitive canine can come because we see the root is blocking, or sometimes the root of the baby teeth is not in the same axis, so it's blocking. So that's when we extract baby teeth, mostly canine and sometimes baby molars.
Okay.
When they are blocking.
Okay, so I think we have reached the end of our question. Thank you so much for answering
Thank
all
you very
these
much.
questions.
Thank
And
you.
thank you for your time and for accepting our invitation and for this really valuable lecture. You really embodied my idea of orthodontics. I am collaborating with an orthodontist right now, so
Nice.
you really embodied my idea of orthodontics. And it was a really a nice lecture. And
Thank you very much.
thank you so much for
Thank you very much, and
accepting.
you can really be proud of what you're doing. IADS, I knew you before, and it's really an honor to speak to you. Thank you very much for the invitation. Thank you, Omar. Thank you, Emiliana, and all the organization. And I always ready to help you or to collaborate with you. Thank you very much.
Thank you so much. I remind all the participants to scan the attendance form and to complete it. And thank you so much for participating and for answering so much and for so much questions
Pleasure.
to the doctor. And see you for the last webinar of the series on June the 13th.
30 next week.
Thank you so much, doctor.
Thank you, Emiliana. Thank you for everything. Good luck. Thank you.
Thank you. Bye.
Bye.